Hi all, I would like to share a presentation with you about suspicious for a follicular neoplasm Hurthle cell type. Firstly, I would like to talk about basics and terms and history. The Hurthle cell, oncocyte, Ashkenazi cell, and oxophilic cell terms are all interchangeable words with the same meaning. These cells have an enlarged round to oval nucleus, prominent nucleolus, abundant acidophilic granular cytoplasm. The excessive number of mitochondria in these cells is the cause of their morphological appearance. These cells were described by different people at different times, but Ewing coined the term Hurthle cell in 1928 based upon the description of a cell by Hurthle in 1894. Lesions that are diagnosed cytologically in this Bethesda category composed of both neoplastic and non-neoplastic. These are multinodular goiter and lymphocytic thyroiditis, Hurthle cell adenoma, and carcinoma. The distinction between adenoma and carcinoma based upon histologic evidence of capsular and/or vascular invasion. The risk of malignancy of samples which has categorized in this indeterminate category is 10 to 40%. 10 to 26% of the cases are non-neoplastic and rest is neoplastic, particularly oncocytic adenoma. In order to emphasize the heterogeneous nature of this category, most of the pathologists prefer suspicious for a follicular neoplasm Hurthle cell type terminology for definition. Aspirates consist exclusively of Hurthle cells. However, Hurthle cells with nuclear features of papillary carcinoma are excluded from this category. The Hurthle cells are dispersed predominantly as isolated cells, sometimes crowded syncytial-like arrangements. Binoculation is fairly common. There is usually little watery collate or no collate. There are virtually no lymphocytes. Except those we expect to see small cell dysplasia, large cell dysplasia, transgressing vessels, and intracytoplasmic colloid inclusion or lumens. In this example, we can see the macrocellular aspirates, isolated cells with oncocytic features. Sometimes these cells in syncytial-like arrangement, transgressing vessels in the middle of the Hurthle cells, intracytoplasmic colloid inclusions or lumens, like that. There are few points to be aware of when using this diagnostic category. Sparsely cellular samples don't qualify for this interpretation. Instead, OS category can be a better option for these cases. Dysplasia by itself is an unreliable feature for diagnosis, particularly large cell dysplasia. These cells can be seen in multinodular goiter and lymphocytic thyroiditis. Cellular cases lacking dysplasia are suggestive of a benign nodule. Sparsely cellular aspirates without atypia aspirates, partial or minimal Hurthle cell differentiations, especially less than 75% of the cells aspirates and clearly abnormal specimen with collate aspirates cannot be diagnosed in this category. Most important differential diagnosis in the non-neoplastic category includes multinodular goiter and lymphocytic thyroiditis. An abundant collate, especially dense collate and lymphocytic lymphocytes prevent to use diagnostic category. Hurthle cell neoplasm can exhibit some of the architectural and nuclear features of papillary carcinoma. On the other hand, papillary carcinoma often show focal oncocytic differentiation. Attention to nuclear details usually permits a distinction. Differential diagnosis includes medullary carcinoma. The prominent nucleolus of most Hurthle cell neoplasms is absent from most medullary carcinoma cells. With Romanowski stains, the cytoplasmic granules of Hurthle cells are blue, whereas those of medullary carcinoma are red. Intranuclear pseudo-inclusions may be seen in medullary carcinoma, but they typically absent or rare in Hurthle cell neoplasms. Granular cell tumor and parathyroid adenoma are both on the differential diagnosis list. Solely morphology cannot help to differentiate these lesions, but immunohistochemistry may help this conclusive distinction. As a result of these Bethesda classification, most patients are referred for lobectomy and frozen evaluation during surgery. There are some molecular tests for optimization of the negative cases to avoid unnecessary lobectomy. However, they are not optimal or very cost-effective for now. These books are my reference books. Thank you for taking the time to listen to me.